Okay, welcome back everyone to our final session. This is the medical legal case, and you know the panel. You can see them listed there. I just wanted to point out that the theme of this conference has been Philip Sunshine and his 40th year, and he's the founder of MCCPOP. And the other theme that we wanted to emphasize was that Phil always made us work as a team and pointed out that this is a team sport, and it is nowhere more important than in the medical legal arena that everybody works together as a team and everybody works together for the welfare of the patient. And our distinguished attorney, Mr. Sheuerman, will be talking about that as well. And I'm going to ask Phil to present Mr. Sheuerman.
Thank you very much, Maurice. Dave has been a dear friend for many years. He came to California when he was 3 years of age from Tacoma, where his dad was in the service. He matriculated at the University of Oregon, where besides his academic excellence, he was the linebacker on the Oregon Duck football team. But a devastating injury to his ankle circumvented his desire to enter the National Football League. So he finished his 4th year at the University of California at Berkeley, and then went on to get his law degree at the University of San Francisco. He practiced in the Bay Area, primarily with the Ropers Majeski firm, where he worked for approximately 15 years, and then opened his own practice in San Jose, where he functioned for the next 25 years. He's been the past president of the California Medical Legal Committee, the only statewide organization of the top trial lawyers dedicated to defending healthcare providers. He and his wife moved to Scottsdale about 2 years ago to be close to their son, who also happens to be a graduate of the Stanford NICU. Dave has also contributed to our textbook, Neonatal and Fetal Brain Injury, has done so for the last 5 editions. And he continues to provide legal care, legal advice pro bono to the Veterans Administration Hospital in Phoenix. So we're delighted to have Dave with us and looking forward to his comments.
Thank you, Phil.
Thank you, Phil. And I just wanted to reiterate that Dave has been a good friend and an incredible attorney for many, many years, always has wise advice, and we're looking forward to his participation today. Next slide. So I'm going to have Nancy present the case, and I will be doing some commentary on the side and bringing in our different experts. Nancy.
All right. So this is a 24-year-old primate at term came in with decreased fetal movement 12 hours prior to admission. Her prenatal and medical history were unremarkable. Her labs were all normal, prenatal labs. She denies any leaking of fluid, but did have some brownish discharge 2 days prior. Her admission vital signs, as you can see, are all perfectly normal. Next slide. And here's her admitting tracing. So again, from our conversation yesterday in complex cases, this is one where it can be a little difficult to actually determine what type of pattern this is. Initially, that first 4 or 5 minutes, it's minimal variability, and then you have this sort of like an increase in the baseline, and it becomes more of an undulating pattern, very similar to sinusoidal. So from a nursing perspective, you know, it's really important when you see a tracing like this with a patient who comes in with a history of decreased fetal movement to pretty much the presence of decreased fetal movement and a sinusoidal-like pattern suggests a fetal maternal hemorrhage unless you prove it otherwise. So you really need to do your initial assessment with asking further questions such as, you know, have you fallen in recently? Have you gotten hit in the abdomen? or, it could be a domestic violence issue as well, since about 1 to 4 or 5 women have domestic violence or domestic abuse during their pregnancy. So it is fairly common. In addition, have you been, in a minor motor vehicle accident? Many women don't even report when they've been hit from behind. Didn't seem like a big deal, but depending on where their seatbelt is positioned, it can actually cause an abruption or a fetal maternal hemorrhage. So it's really important for us to follow up and ask appropriate questions to try and rule it out and look at other maternal fetal risk factors. So next slide. So again, we talked a little bit about this yesterday, but the criteria for looking at identifying a sinusoidal pattern is really, again, a stable baseline of 120 to 160 with regular sine wave-like oscillations, like the last part of that strip, an amplitude of 5 to 15 beats per minute, a frequency of 2 to 5 cycles per minute, fixed or absent short-term variability. That's kind of an old term that we used to use, but basically absent variability, and absence of acceleration. So on that slide, you didn't see either of those, no accelerations or variability at all. Next slide. So again, sinusoidal patterns are not always symmetrical and continuous. They can be intermittent. So you can have patterns in between that don't look so sine-like, but more, like a sawtooth pattern. But the more blunted the undulations are, the worse the anemia is. So when you have a marked sinusoidal pattern, it's the greater risk of acidosis of the fetus. Next slide. So sinusoidal patterns that are pathological result from the absence of CNS control over the heart rate caused by fetal hypoxia, acidosis, or asphyxia. And they're usually associated with either fetal anemia, fetal hypoxia or asphyxia, fetal infection, or sometimes fetal cardiac anomalies. Next slide. So here you see a true sinusoidal fetal pattern. And again, it's very clear when you see this with it's a sine wave undulating. There is absolutely no variability, and that's a smooth undulating pattern. And this is, again, a pattern that is fairly frequent when you see fetal maternal hemorrhage. Pseudosinal patterns, again, look much different. They look more sawtoothed. They are more common than true sinusoidal patterns. And sometimes within these, and like you can see after the third contraction, there's a little acceleration there. And some variability in this. So it's not smooth like the other one. There's sawtooth pattern, there's accels, and these are associated generally with either narcotic administration or analgesic medication, or sometimes, you need to ask women if they've taken any narcotics prior to arriving at the hospital. These are generally benign. The fetuses are not hypoxic, acidotic, or asphyxiated with these type of patterns. And they usually, once the medication wears off, they go back to normal.
Okay, thank you, Nancy. We can just pause for a minute.
Mhm.
And I'm going to ask Dave to make a few comments. First of all, Dave, could you just outline for the audience in a very concise way, what are the elements of a lawsuit? Because most people, fortunately, in this audience are not going to have experience with that. But what are the elements of a lawsuit? If you have a bad outcome, what does the plaintiff have to do to be able to get a verdict for the client?
Well, okay, hopefully we can keep everyone in this seminar from having to experience what a lot of my nurses and doctors have told me over the years was the worst experience of their life. The person suing you has to prove 4 basic things. First of all, you have to have a duty of care. In other words, the person suing you has to show that there's a relationship between you and the patient, giving rise to an obligation to use the requisite skill and care of a registered nurse or a physician, obstetrician, neonatologist. The next thing they have to show is that you breached that duty, that you were negligent because you didn't use the care and skill that a reputable nurse or doctor would use in the same or similar circumstances. The next thing they have to prove, so as long as they can prove those two things, they go to the next step, which is causation. And I understand that's going to be an issue in this case, that whatever you did that was deemed negligent was a substantial factor in causing the injury. So for instance, if you didn't look at the strip for the first hour and didn't note you monitored it, but nothing happened in it and nothing would have been done anyway, then there's no causation for your negligent act. And then the final thing they have to prove is damages. Those are two basic categories. General damages, that's, I will suffer pain and suffering for the rest of my life because of what you did to me. And because those kinds of damages are very hard to determine for a jury, a lot of states have put limits on those damages, especially in medical malpractice cases. The other element of damages which are not limited are economic damages, and that's what it costs to take care of the injured person, give them medications, supplies, lost income, things of that nature.
Thank you, Dave. Now, in this particular case, as Nancy pointed out, when the patient came in, it looked like it looked like a normal strip for a little bit. The strip bumped up, and then there was maybe a pseudosinusoidal and maybe a sinusoidal pattern, but it wasn't clear. And in terms of presenting a case and expert testimony, what is the requirements for an expert? That's number one. And number two, what if you have one expert saying, oh, this is clearly sinusoidal, and the other one saying, oh, I think this is pseudosinusoidal, because one is category 3, you need to go, the baby may be acidotic, and the other one is, as we have up right now, not hypoxic, acidotic, asphyxiated. So could you please address the issue of expert opinion and then differences in experts and how you address that in the court?
The issues of negligence, usually duty is not an issue. It was the nurse assigned to the patient, the doctor assigned, etc. So the big issues are usually whether the doctor or nurse breached the duty and causation. And those are both decided by experts on each side. And actually the jury ultimately decides who they believe, but it's the court instructs the jury that these things are a matter of not of common knowledge, and therefore they are to rely on the experts to make a decision. So after weighing the qualifications of the experts and the reasons they gave for the opinion, the court says if we have conflicting expert opinions, which we always do, you should weigh the reasons given for the opinion, the facts relied on by the expert, and the relative credibility, special knowledge, skill, expertise and training and education of the particular expert. So we always have a battle of experts, and I try to get better experts than the other guy does. They're tailored, of course, to the case. And in a case like this, you would need a perinatal nursing expert, a obstetrician, a neonatologist, and perhaps others for causation issues, maybe a radiologist to read the film and tell us topographically in the brain where the lesion is, etc. So that's how that is decided.
Thank you. And I know that the reason you used Phil a lot was because he looked so benign that all the juries loved him and believed everything he said. So there you go.
But then bam, he came out with it and killed him.
Okay, Nancy, let's continue with the case then.
All right, next slide. So the goal for this patient is really, getting her admitted, continuous fetal monitoring, and begin to initiate the intrauterine resuscitation measures, reposition her, give her an IV fluid bolus, put some O2 on her, and make sure that the physician is notified to come in for a bedside evaluation and review the tracing. It's also important at this point, because she came in already, with no reassuring tracing at all to begin with, and a history of, decreased fetal movement for 12 hours, it will be really important and prudent to make sure that the charge nurse is aware, to make sure that there's communication to the rest of the team, and that includes the NICU, the anesthesia, your OR crew, to just be aware and be ready in case. Because again, with these kind of cases, as if it is a sinusoidal pattern, this is a category 3, and she needs to be delivered, as quickly as possible. So it's really just important to make sure that everybody is aware and you know where everybody is and how to get a hold of them. Next slide. So the two things you need to look at is ruling out decreased placental perfusion and fetal acidemia and acidosis, fetal anemia, and possible fetal maternal hemorrhage. We could rule out acidemia if she had any ACT cells, which she hasn't shown yet, or variability. So we can't really rule that out at this point. And so all we can go by really is her history, and she didn't really have any history that would indicate that she had a problem prior to arrival. So reviewing her prenatal record, bedside ultrasound sometimes can be a benefit. The Kleihauer-Betke blood test that we talked about yesterday would be good, just to monitor how many fetal blood cells are in the maternal circulation. And then you can try acoustic stimulation to try and elicit fetal movement. So using a artificial larynx and trying to see if you can usually you can stimulate an acceleration of that 15 by 15 beats per minute, will then rule out acidemia for the fetus. Next slide. And this is the Kleihauer-Betke blood test. I don't know if you want to go over that at all, Maury.
No, I think because in the interest of time,
Yes,
let's just move on with the
right.
strip.
Next slide.
And let's just do the right-hand side here.
All right. So this is an algorithm for decreased fetal activity. And again, you normally would evaluate her. She did not have a non-stress test. But if you go down to the bottom of the right side, you'll see between 32 to 34 weeks or more, which this person, she's at term, you would indicate to deliver her if she does have decreased fetal movement with a sinusoidal pattern.
Okay.
Next slide. 50 minutes later, now you can see really minimal variability. It's not the undulating pattern. It looks more like a pseudosinus pattern with a prolonged deceleration. And next slide is a continuation of this pattern. And you can see a very slow recovery back to baseline of around 135 or so, again, with minimal variability. So here you again have, it's not a sinusoidal pattern, but it could still certainly be a pseudosinusoidal pattern. So next slide. And this is that slide I showed you earlier. Again, it's more common than sinusoidal patterns. So again, it's something that we need to, you can't really substantially say that it's a problem, so we need to continue to monitor her. However, 2 hours after admission, this is the final tracing that we see, and this is definitely a sinusoidal pattern with that smooth, sign-like undulating pattern. Next slide. Again, it looks exactly like this pattern. So next slide. So her hospital course is fetal heart rate showing decreasing variability in the last 50 minutes. The episode of sinusoidal pattern was clear in the last 10 minutes. So she got a diagnosis of probable fetal maternal hemorrhage. PEDS was notified prior to delivery. They did follow through with that of possible severe fetal hemorrhage based on the appearance of the sinusoidal pattern. And next slide. Maury, I'll let you go through this one.
Yeah, so I think, there are a number of reasons for decreased fetal maternal hemorrhage. And most of them are unknown if you look at the bottom of the slide. Next slide. The key points are decreased to absent fetal movement in combination with any abnormal fetal heart rate pattern, which is minimal absent variability, late decels, and classically sinusoidal pattern, but not always, should raise the index of suspicion. And if you have minimal absent variability for at least an hour, that is a very good predictor of acidosis. Next. So this baby was delivered, appeared pale, floppy, pure responsive with low APGARs and birth weight of 3.9 kilos, and no cord gas was done. And before we hand it over to our pediatricians, we're going to have plenty of time. Dave, I'd like to ask you to comment on the obstetrical management. So this patient came in with that initial strip. It sounds like everything was done appropriately in terms of evaluating this patient. There was some concern about a pseudosinusoidal versus a sinusoidal, but at the time that they made the final decision that this is a sinusoidal pattern, luckily the patient was moving along and was delivered quickly. Is there anything in this particular case that would have I'm sure the plaintiff's going to say that they should have done the C-section when she came in and had that first episode of sinusoidal pattern, but then somebody may argue, well, it wasn't clear that that was what it was, and the follow-up tracings were more confusing, more pseudosinusoidal, and then finally it was sinusoidal. But could you argue that she should have been delivered earlier? And then, of course, you'd have the experts having their discussion.
Well, I guarantee that every plaintiff's lawyer on the planet would argue that a C-section should have been done sooner, because they say that in every single case like this, of course. And they get an expert to support them. The thing that troubles me about the case is that the absence of variability, that's a hallmark of a depressed infant. And so if you've got a probable diagnosis of fetal maternal hemorrhage, you call the pediatrician, and I guess they're the ones that should order the blood, but it wasn't done, as we'll see in the later slides, in a timely fashion. This would be a pretty easy case for a plaintiff attorney to convince a jury in retrospect, when they wheel that child into the courtroom in a wheelchair that's making noises that you don't want to hear, and some of the jurors start crying, then it's a pretty easy case to make, even up to this point.
Dave, can we just go back a little bit to the obstetrical side? Because let's say they're represented by obstetricians have a separate representation and peds have a separate representation. They've each got separate policies. Could you make the argument on the OB side that the obstetrical management was appropriate, given that it wasn't very clear? And I understand that you can have experts having a discussion, but if the experts agree that it wasn't clear until the end and then she delivered very quickly thereafter, could you say that there was no liability on the obstetrical side? Would that be an argument you could make?
Well, certainly if the experts all agree that it was expeditious, then there's no argument.
Right.
Experts will never agree to that, and the plaintiff
right.
will agree to that.
Okay.
But,
all right.
But it's definitely a legitimate argument to make as a defense that, if you have those kinds of sort of ambiguous findings, I don't know that it's all that ambiguous given the lack of variability, but I could defend it with a straight face, but it's not great.
Okay. All right. Next slide. I'm going to let Ron and Phil take over. Now,
Okay.
just one point I do want to make is that neonatology were notified, pediatrician was notified that there's a sinusoidal pattern, that you're likely to have a very anemic baby, just to give you the heads up, and that was done at least half an hour before the delivery.
Go ahead, Ron.
Okay, I get Phil, are you going to do this or I?
You are.
Okay, thank you. So there was a capillary blood gas at 35 minutes of life with a pH of minus basically 6. But the first hemoglobin and hematocrit weren't obtained until over an hour of age. And you can see the hemoglobin was 3.3 and the hematocrit 9.9. There was a white count of 12.2 with an NRBC of 12.3%. For the math majors in the audience, that comes out to over 1,500 NRBCs, very definitely elevated. Blood was then ordered stat, but not until the baby was 90 minutes old. Unfortunately, the blood bank would not release the blood because the only O negative blood they had was 9 days old, and they said they would not release blood outside of a 7-day age limit. Next, please.
Dave, could I just 1 second, Ron? So if the blood was 9 days old, 2 days over expiration, Ron, did that mean that the blood was just worthless or toxic, or what is the implication of that? I mean, if you don't have anything else, would there have been any harm in giving that blood to the baby rather than waiting for blood that was not that old?
Yeah, I don't know what they mean by 9 days old. You can actually store blood frozen for up to 42 days. We try to use fresher blood for neonates, but frozen, it's good up to 42 days. And I think maybe this blood was in the refrigerator, and that would be more of a problem.
But would it be a problem for acute resuscitation if there were no other blood available, is my question.
I think at a time like this, there needs to be a negotiation between the doctors taking care of the patient and the blood bank. And I know I would have strenuously argued with the blood bank that I don't give a damn if it's 9 days old. This kid needs blood now. The big risk of 9-day-old blood is that the child might get hyperkalemic. I would rather treat hyperkalemia than severe anemia.
Okay.
I can give Lasix and saline. So I would personally have negotiated with that blood bank and requisitioned that blood. You
So
can
Dave,
you can override them and sign a release.
Any
So
expert,
Dave-
I agree with Ron, any expert's going to say the failure to minimize the risk or the extent of the complication by not giving the blood, regardless of the age of the blood, is negligent, especially in this situation. Although it piqued my interest when we have a 1,500 nucleated red blood cells, because that might give us a little room to argue causation.
right. Okay. Sorry, Ron, continue.
Okay, so you can see now at 2 hours of age, the baby was even more acidotic with the base excess down to -2, and the hematocrit had further decreased from 9.9 to 8.3. The blood pressure was not great, but not terrible. I don't know what the kid's heart rate was doing, but I would suspect the kid was tachycardic. Finally, a transport team arrives at 3 hours of age and places umbilical catheters, at which point the blood pressure is even lower. And remember, we'd like to see a mean blood pressure higher than your gestational age. And this child was basically at term, so that's a fairly low blood pressure at this point, with a very low diastolic. I think next slide. The transport team brought their own blood and started to transfuse the child as soon as they got lines in, which meant slightly over 4 hours of age. And they gave 40 mLs, an estimated 10 per kilo, over the next 40 minutes, twice, so a total of 20 per kilo. Unfortunately, by 24 hours of age, the baby began to show seizure activity. Next slide, please. So the first question is, where did the blood go? Next slide, please. So this is a slide showing the incidence of fetal maternal hemorrhage over time, singleton births in the United States up until about a decade ago. And you can see that there's a slight downward trend initially, but it pretty much flattens out. Next slide, please. Next slide, please.
Hey, Ron, can I
Yeah.
interrupt you for a sec? There's a
Please.
question in the Q&A about, can you just talk a little bit about what the nucleated red blood cell count is?
Sure. Can we go back to that? Oh, we went too far. Forget it. So the NRBC, forgetting the exact numbers here,
1,500.
nucleated red blood cells are sort of immature red blood
1,500,
cells.
Ron.
Yeah, what?
It was
Was 1,500.
1,500.
Yeah, doesn't really matter. The nucleated red blood cells are basically immature red blood cells that tend to stay in the marrow. A small amount leaks out, but when the body is stressed by severe anemia, they come out of the marrow over time. So the height of the NRBC indicates the degree of stress, either hypoxia or anemia. And the higher it is, generally, the longer and worse that stress has been. So it takes a while for the NRBCs to come out and show up in the periphery, and then they hang around for a little while.
So is
That
it possible
answer
that
the
this
question?
baby may have been damaged earlier than on presentation to labor and delivery?
Well, the question one has to ask is, when did this fetal maternal hemorrhage occur? And I'll talk about that a little bit more as we go along, but I would remind people that this mother on the very first or second slide commented about a brown discharge 2 days prior to admission. And I would just put that in the back of everybody's minds as we go along.
Okay.
Okay, so I think next slide, please. Whoops, no, back one, I'm sorry. So what this basically shows you is practically everything is associated. If you look at your right side of your screen, I don't know if you can see the pointer, all these highly significant P's, less than a gazillion zeros. So this is not very helpful that a lot of things are associated with fetal maternal hemorrhages, because yes, they can happen in car wrecks, and yes, they can happen when you fall down, but they can just plain happen in otherwise uncomplicated pregnancies. Next slide, please. Okay. What's always amazing is how much blood a baby can lose in a fetal maternal hemorrhage. And this is one of the earliest attempts to try to calculate the percentage of total fetal placental blood in the maternal circulation. And you saw that Clay Howard-Betke slide before. We know roughly what mom's blood volume is, and by figuring out what percentage of her red blood cells are fetal red blood cells, and knowing mom's blood volume, we can guesstimate how many cc's of fetal blood were mixed into the maternal circulation. And you can see here that this is a huge volume of blood in the kid. I mean, these kids, if you go over to the one slide, one column over, 355 mLs of fetal blood loss in a 3-kilo kid, that's their entire blood volume.
No, that's the total blood volume, and the right-hand
Oh
side
yeah, sorry.
is
That's
the loss.
almost half the kid's total blood volume. So there's huge amounts of blood lost in these kids. All right, 177 ml out of 355. That's huge amount of blood loss that these kids can have in utero. Next slide, please. All right, and so this is factors that seem to affect the outcome. And I'll tell you right off that a lot of these data are somewhat confusing. And one of the reasons is that all these fetal maternal hemorrhage cases are a mixture of both very acute last second fetal maternal hemorrhages versus longer term fetal hemorrhages. And there's no good way for these people to control for that in these retrospective studies. But you can see in this slide that adverse outcome is up dramatically in kids who have pallor and symptoms, and in kids whose hemoglobin is less than 4.
So, Dave, given what Ron just said, if this was a remote event that occurred before they appeared on labor and delivery, is that a good defense in terms of causation versus an acute event that only occurred at labor and delivery and wasn't managed well?
I would be hiring the best expert in the country on NRBCs to explain why it takes 48 hours to develop that many NRBCs or whatever it takes. and that this wasn't an acute event, because although it's a lay jury, they're pretty wise collectively. And if you get a good expert who can explain to them the medical issues and the pathophysiology, they can get it, and they'll defend the case.
Okay, sorry, continue, Ron. Thanks.
So, all right. So next slide, please. Yeah, so I'm just highlighting for you again the relative risk, the 40 some odd times increased risk. Kids who are born with pallor and symptoms and with a hemoglobin less than 4, both of which describe this case. Next slide, please. Okay, this is another slide trying to predict outcome from hemoglobin levels at birth. It's the same study, just putting it a different way. And again, you can see that for higher hemoglobins, many of the kids turned out normal, but for hemoglobins less than 4, the majority of the kids either died or had severe PVL, and a small number, smaller percentage turned out normal. Next slide, please. Okay, this is from a different survey looking similarly. They tried to calculate from the blood volume, calculated blood volume loss, and looking at the outcome. And again, though it's not 100%, you can see that the kids at the bottom of your slide, I think that's highlighted on the next slide. Does it highlight it? Yeah, there you go. Once you go below that red line, the higher volumes, you can see that it's not 100%, but it's a much higher percentage of the kids end up with fetal death and end up with adverse outcomes. Okay, so once again, larger bleed looks like it's worse. Here's a more recent study in neonatology just 4 or 5 years ago with initial hemoglobins less than 6, and I believe this kid's initial hemoglobin was 3. 63% survived, but there were lots of kids with lesions in the basal ganglia and thalami, especially in the white matter. The severity of anemia did not influence the need for intensive care, and they did not see a difference in survival between patients with a hemoglobin less than 3 or patients with a hemoglobin between 3 and 6. However, the degree of organ failure and the degree of encephalopathy score, or abnormal EEG, did correlate with the severe injury on the MRI. So again, though a low crit is bad, because some of these kids were more acutely bled, some of these kids more chronically bled, it isn't a clear-cut demarcation. Next slide, please. This slide describes the MRI patterns of the brain injury caused by severe anemia at birth. And the point of this very complicated slide is that severe perinatal anemia like this causes a different pattern of MRI brain injury. Next slide, please. And the point is the predominant site of the injury with this is white matter, as opposed to HIE and NE, where neuroencephalopathy, where the injury tends to be either cortical or more commonly even than that, basal ganglia. Okay, next slide, please. And this is actually pictures showing you severe white matter injury. Again, I don't know if you can see the pointer, but all of this stuff here posteriorly in the white matter, that's abnormal. And you can see in slide D, the evolving PVL, cystic changes in the posterior white matter. Next slide, please. Okay, so key points and QI opportunities, Maury?
Yeah, so I think some of the key points that need to be discussed is we've already spoken about it, that the obstetrical service did notify peds of a problem of fetal maternal hemorrhage and severe fetal anemia, but the preparations for immediate blood replacement were not instituted in a timely fashion. And then there seemed to be delays in determining the hemoglobin hematocrit and in administering blood products. And then finally, I think we already discussed this, the systems issue regarding expiration of the O negative blood, even being 9 days old outside of their 7-day age limit. Next. Okay, so I'm going to ask Dr. Sunshine to make some comments about the case, particularly about the timing of the injury and the MRI findings. I think you had some thoughts about that, Phil. And then I'm going to ask Dave to summarize what his approach to this would be if he were the defense attorney, and whether you would just walk in and say, how much do you want? So, Dr. Sunshine.
Okay, I just have a couple things that are sort of peripheral to the questions that you posed, Maury. First of all, the Kleihauer-Betke is a test that can be readily done pretty much in any laboratory. A more sophisticated test is a cell sorter, where you can actually see and get a better idea of how many fetal cells are in the mother circulation. Unfortunately, not every laboratory is prepared to do that. But I think the case in this particular case, and I don't know if they ordered the Kleihauer-Betke before the baby was delivered or after the baby was delivered to make the diagnosis. Second point is that the blood bank really did make a big error here by failing to release the blood in a critical situation. It turns out that if you look at every community or intensive care unit, nursery, pretty much in our state, has in their neonatal unit a unit of blood that is O negative, CMV negative, that is readily available and usually less than 3 or 4 days old. So they can give an immediate transfusion to a baby who comes out in a situation like this. And they also have it available in case they have to prime an ECMO program really quickly for kids who need it. And that blood can also be used for a mother who has severe hemorrhage. And it turns out when I talk to the people at the Stanford Blood Bank, they release blood that's 14 days old, and they don't have a recommendation or a hold if it's more than 7 days old. And I try to find out if there's any state directives or county directives or national directives, and there really aren't as far as when they should, how old the blood can be before they release it for neonates. I can't find that, and I've asked the blood bank to look into it, and they can't come up with a directive either. The other thing is, this is probably, and I would say absolutely not, an acute bleed. The data that we have show that if you have an acute bleed of this much blood, and most of the data are in laboratory animals, show that the fetus would not survive even for a short period of time. So obviously this blood loss was going on for a significant period of time. And in order for the baby to respond in utero, there has to be, when there is anemia, there's a release of erythropoietin. And erythropoietin then stimulates the production of new red blood cells. And to see this many nucleated red blood cells in the baby's blood would suggest that this has been going on for at least 2 days, probably more. And other thing that if I were called as an expert for the defense, I would have said no matter what they did, whether they delivered this mother the minute she came in, whether they had blood readily available to give the baby immediately, an immediate transfusion, I think this baby would have already had significant damage. And no matter what they did, this baby would have ended up, as this baby did, with significant damage, found an MRI to the central nervous system. And I understand this baby ended up being quadriplegic, as well as severely mentally incapacitated.
So, Dr. Sunshine, thank you for that summary. And looking at you speaking to the jury, they would have bought that hook, line, and sinker. I mean, you've just won the case for Dave. He started with a case that was unwinnable, and here comes Sunshine with the ninth inning, bottom of the ninth, 2 outs, and he hits his home run. Just in the true Willie Mays fashion as a giant.
Well, but
So,
he just put the game into overtime, and now we're starting out with a runner on second base. The runner on
Okay.
second base says
Okay,
that,
let's,
yes, the kid would have been damaged, but maybe it was worse because of the delay in treatment.
Exactly.
David?
so now we're going to go back to Mr. Sheuerman. Dave, could you please summarize the case?
It
Because
raises
it's,
a host of issues, but Ron just hit one of them on the head. Even though we'd have the nucleated red blood cell defense that had happened earlier, everybody there had a duty to minimize the risk of the complication. And when you look at the fact that blood was given 2.5 hours after it was ordered stat, I mean, that's kind of hard to defend. So the jury maybe gives the baby the benefit of the doubt on that one. So defending, I think the obstetrical care could be defended. The hospital on negligence, they're dead. They have a duty to provide facilities and supplies and personnel reasonably necessary. So they don't have blood, for whatever reason, they're cooked. And the pediatricians / neonatologists look like they're in pretty bad shape too because of the delay in getting the blood in there, regardless of its condition or whatever. So very tough to defend on the negligence side for everybody except the obstetricians and
and the nurses.
Well, okay, so I'll get to the nurses. Now, the nurses have a duty to ensure the patient's safety. That means they got to go up the chain of command. Things aren't happening fast enough. They get criticized for all these things that we would think, that never happens, but they'll get criticized for it. And they're all employees of the hospital, which is where all the money is, which gives the plaintiff's attorney great incentive to blame the nurses because they're employees of the hospital, whereas in a community hospital, the doctors would be, independent contractors with $1 million in insurance, and the hospital's laden with cash to pay for this kid's injuries.
Okay, but Nancy, if you look at this from the nursing perspective, do you feel that the nurses acted according to your standards, the A1 and other standards? Do you feel that there would be an argument that the nurses should have gone up the chain of command?
That's a hard question to answer because, again, I think even though, there was decreased variability in those periods where there was not undulating sinusoidal type patterns and accels, I think, at that point, within 30 minutes of that strip and you couldn't elicit an accel via, doing acoustic stim, potentially, yes, they could have accelerated their communication to the team and, had a physician there at the bedside and, perhaps go ahead and do a C-section. I don't have all the, documentation of, the conversations that took place, but this is where it would be really important in the nurse's documentation to make a narrative note of the conversations that they had with their provider. Because, as when we're using electronic health records, it's really hard to paint a picture of what actually took place unless you do a narrative and really explain what the conversations were, what the response to that conversation was, timelines, all of that, because it's really hard to audit a chart and try and find all that information.
So Dave, I want you to have the final word on documentation.
The documentation is crucial. Every healthcare provider, of course, your primary duty is to provide excellent care for your patient, but that can detract from your ability to chart in a timely and accurate fashion. And charting is the best defense that you have for yourself once a malpractice case is filed, or if the nursing or medical board launches an investigation of you. If you haven't charted certain things in a timely fashion, you're going to have a problem. Now, in most jurisdictions, these cases don't have to be brought for 7 or 8 years because oftentimes the kids don't declare their developmental delay until that time. And so a common scenario is baby's now in the 3rd grade, child begins manifesting delays. The parents go to a lawyer looks at the chart, sees a lot of charting deficiencies. He takes the case. Now you're on the stand 7 or 8 years after a day on your job where you didn't chart, trying to remember what you did that day to show how attentive you were. And that's a tough thing to do. So charting is absolutely critical. And the EHR, that's a whole another topic on its own, but that creates a lot of other important issues as well.
Yeah.
Well, thank you, David, and thank you to the panel for a very interesting discussion and a great case. And I don't know if there's time for questions, Christina. Are there some questions?
Hi, Maury. A couple have come in. I think one of the focus definitely it was on the blood administration. And is there really a standard of care for the time of blood administration after it's been ordered staff? So focus on blood administration. And then the other one, what about the cord gas?
It wasn't obtained.
Why? Well, any insight into that?
No,
I don't
just
want to be a broken record, but I said
didn't
this
happen.
yesterday. It would have been really nice to look at this kid's placenta. I
Yeah.
see Mr. Sheuerman nodding his head, but that placenta could have settled a lot of questions. I mean, if there was hemorrhage in the placenta, if there was old clot in the placenta, that would have helped determine an awful lot of what went on.
Dave, repeat what you were just going to say.
Yeah, the placental pathology experts have saved my rear end many times. And Ron's right. I mean, you can get a lot from a placenta that is, and it's undeniable. You know,
that's a great take-home lesson for everybody who's listening, whether you're OB, pediatrics, or others. So thanks for that comment. Any other questions or comments?
You know
Christina?
what? I think we're good. And I think we just need to acknowledge and thank Dave for joining us again. And then we'll move on to our closing thoughts.
Thank you, Dave. Thank you, everybody. I just wanted to make a few closing comments. I'd like to really thank our staff, Valerie Cape, Melissa, and Christina, for just a fabulous, and everybody else in the office. I don't know all of your names. I apologize, for an absolutely fabulous presentation, for a very smooth conference that was, in my opinion, just incredible. Seeing that this was our first virtual conference, I just think we could not have done it without the expertise of our staff. And then I'm going to turn it over to Dr. Sunshine to maybe make some closing comments about our 40th MCCPOP and your thoughts about life, Phil.
Well, first of all, I never thought we'd reach 40. So things are good. But just to reiterate what Maurice said, to thank the staff for all their diligence and help putting this together. I want to thank all the faculty who participated and really spent a lot of time learning new techniques and working this out, so we had a pretty good virtual conference. I would really appreciate the participants who I acknowledge. I want to thank you very much for attending these 2 days and asking important questions, but I would really appreciate if you could fill out these evaluations and tell us what you thought of this virtual conference. And we would like to take this very much to heart. We'd like to be able to identify the weaknesses, the strengths of the program so that we can improve the weaknesses, build on the strengths, and see if we could make headway if we decide to do future conferences. We're looking forward to having the 41st conference back in Monterey in March of 2021. However, we would also like
22.
Oh, I'm sorry, 22. I wrote down 21, 20 years behind. In March of 22. And we hope to have a live meeting at that time, and it will be held at the Monterey Plaza Hotel. However, I really would insist that we have the opportunity to still provide a virtual conference as well to run simultaneously in order to keep many of the new friends we made through this virtual conference, and hope that they would join us again in our future meetings. That means next March. So we want them to continue to be part of the MCCPOP program, even though they're not in California or even in the United States. So I want to thank you all for your contributions and look forward to seeing you next year.
Thank you, Dr. Sunshine. Thank you,
Thank you,
everyone.
sir.
Thank you.
Next
Thank
year
you
in
all.
Monterey.
Sounds good to me.
Everybody get vaccinated and stay safe. Take care.
Absolutely. Bye, everyone.
Have a great weekend.